The first one, which was kind of intentional, was that there's no basic like guidelines or references for calories or protein for someone who has AIDS, right? So I kind of went around and talked to most of you, and most of you had the right idea. But there's no specific range, which in reality, when you're in a clinical setting and you go see a patient, you're not going to have this range that you're working at. But as you're deciding or what the needs for the patient should be, there are a couple of things that you want to take into consideration. What are the patient's stressors? Okay, with this patient in the case study, once that state of seroconversion occurs, once they develop antibodies to the virus, they enter this lifelong inflammatory state. So they're under a state of constant stress and constant inflammation. So automatically, with having HIV, their needs are going to be elevated. Okay? It's considered a state of physiological stress. So they're going to have increased protein and increased calorie needs. When we look at our patient, we see that even though his BMI falls in the lower end of normal, we would consider that he's lost 15 pounds unintentionally. And the key word here is unintentional weight loss. If someone is losing weight intentionally, perhaps they're losing mostly fat, because hopefully they're exercising. But when someone loses weight unintentionally, we begin to think that they're probably losing lean body mass. That becomes an issue. So that increases their risk of being malnourished. So we have a patient that is at risk for being malnourished. He has oral irritation, so probably not eating the best. Needs are increased. And one of the biggest things with age, just like with cancer, we want to prevent someone from being malnourished. We want to stop that process before it occurs. So his needs are going to be increased. If we know that maintenance needs are 25 to 30, we can estimate that this patient is probably going to need greater than 30 needs, right? 30 calories per kilogram. So a lot of you I talked to recommended somewhere between like 35 or 32 to 36 or 35 to 40. Either of those would be appropriate. I think when we look at it, it gives somewhere between about 2,400 to 2,700 needs, or 2,800. Does that make sense? We used his current body weight for him. Did everyone use current or did you use usual? There's no reason to use usual, so we use current for him. Protein needs, same thing, are going to be increased. I talked to a lot of you, probably think that he needs greater than 1. So I wouldn't use 1 in my range, but probably somewhere between 1.2, 1.5, 1.6 would be appropriate for this patient. Again, I think that gives him somewhere between 80 to about 100 grams of protein that he needs. The other thing that always comes up, and I think this is a really valid concern, is sometimes people will tell me, well, he's having oral irritation and he's not really going to be able to consume that amount of calories. And I do think that that's a very valid concern. But we want to estimate needs based on what we think the patient needs to heal overall. So we estimate needs that are increased, and it's our job to figure out how to get him to eat those needs, how to get him to eat that many calories. So again, talking to a lot of you, you told me things like soft foods, right? Does that make sense? Some people told me calorically dense foods, like they recommended, and I thought this is a really good idea, like doing mashed potatoes with cream and butter and cheese and everything to increase the caloric density of it. What else did you guys come up with for that question? Smoothies, supplemental drinks to get the calories and protein up, whatever we can do to increase his needs. Remember, we don't want the patient to be malnourished because once they start to become malnourished, it's very difficult to turn it around. One of the other questions talked about food safety. What are your concerns with food safety for this patient? And why are you concerned with food safety?
Is there a risk of infection?
Very good. He's at risk for getting food poisoning, right? Because his immune system is compromised. So I noticed one of the things on there said that he doesn't like vegetables except salads. Probably can't have salads, okay? Probably can't have salads. And then you notice that he didn't like a lot of meat, like especially not beef, probably because it's a little bit more difficult to chew. It also talked about him not being able to tolerate milk. Oh, I'm sorry.
I was gonna say, because he's a bachelor and he probably eats out a lot, one of the things that we really want to talk to him about is checking the health rating at the restaurants that he goes to make sure that the places he's going to are like actually safe.
That's really important. Sometimes we don't think about that. We assume it's safe because it's a restaurant, and it's not always safe. That's very, very important. Especially at places like buffets and things like that, we'll usually encourage them not to eat at buffets just because there is a lot of raw food and there's hands and things like that around, and it's held out for a while. And then there's the milk. He can't tolerate milk. Why do you think that is? It's GI tract, right? Remember we said that that's where the macrophages are, and then that's where the virus harbors, and then that can affect his ability to metabolize lactose. So that may be why he's having issues with that. Medications. So we didn't talk specifically about medications we didn't talk about specific ones, but we will. There are a couple of things I want you to know, and they are in the slide. One's called the HAART, which is what he was on, right? That stands for highly active antiretroviral therapy. Highly active antiretroviral therapy. What that means is you're taking a combination of specifically 3 or more medications that interact with that HIV life cycle at different points. specifically 3 or more meds that interact or interfere with that HIV life cycle at different points. Remember when we watched the video, we talked about transcriptase and the protease, and I said those are enzymes that facilitate that process? Well, if you looked up some of those medications, one was a protease inhibitor, which means that particular medication is going to act at that specific step and interfere with that step occurring. The other one was a reverse transcriptase inhibitor. So that's going to interfere with reverse transcriptase. So that HAART is often what we hear commonly called like an AIDS cocktail. Okay? And that cocktail is going to take multiple medications. They interact at different points. And if they're interacting at different points, the thought is we can stop the replication. If taken consistently, which is about if 90% compliance or better, they're pretty efficient, okay? If they're taken like they're supposed to be, we can prevent the progression of HIV to AIDS. What happens is they cause so much discomfort and other barriers that compliance is usually not 90%. So then that's why the immune system continues to be attacked and patients progress to having AIDS.
I remember watching this years and years ago, like this beauty queen, and she ended up with HIV, and I think eventually got to the AIDS. But she had to take, like it took you through her morning like routine, where she would have to take like 20 different pills, and then a lot of times she would be like in the middle of the process, and then she'd throw up, and then have to like start all over again. Is it still that intense?
It's probably not that as bad anymore, but it's pretty intense. It's pretty intense. People aren't just not taking them because they don't want to take them. It's very difficult. There are a lot of GI complications associated with them. So the barriers to that compliance, a lot of times you'll just read the numbers and say, well, if 90% compliance prevented, just take them. It's not that easy to do. It really isn't. So it may have improved some, but I think you'll see that there's still a lot of barriers to compliance. So that's why it's so difficult to take them. So these are just things to talk about. We read a lot of things in the textbook, but I'm really glad she brought that up because when you're actually working with a patient, you want to think about those things. We don't want to judge them for not being compliant. A lot of times there are reasons that makes compliance so very difficult for them to follow. Okay? Does anyone want to share? Oh, one more thing. And so number 19 asks you about a lot of different, what we call complementary medications, right? That one, fill that chart out to the best you can. If you didn't fill it out completely, that's okay. There's a reason why I wanted you to do that. Complementary medicine is a very common practice in patients that have HIV and AIDS. So a lot of them will either megadose with different vitamins or take different herbal supplements as a way to treat the illness. The problem is, we know overall, what's the biggest things about supplements? They're not regulated. So the fact that you're taking the supplement that says it's euthanasia or St. John's wort, it has this in it, it's not regulated, so we really don't know what you're getting in that bottle. The other thing is that a lot of times patients, when they ask them what medicines you're taking, they won't list complementary meds because they don't consider them to be actual medications. The problem is a lot of these medications interfere with the antiviral meds. Okay, so a lot of them will interfere with the specific meds they're taking for HIV and AIDS. So we want to be very careful of that. But it's a very, very common practice. You'll also see megadosing of your antioxidants like vitamin C, E, and A. And if you think about it, antioxidants reduce oxidative stress. They help fight infection. They help heal. So the thought behind it is that by megadosing, which giving very high doses of those antioxidants, can help with the infections that these patients may experience. You guys also look up lipodystrophy for me. What is lipodystrophy?
It's just like uneven distribution of fat.
Mm-hmm.
The adipose cell.
Why does that happen? Long-term use of the antiviral meds. So it's a side effect of the medications. It changes the way that fat is distributed on their body. So I probably should show that video that you're talking about, but when you see these patients, they can be emaciated everywhere else because they're malnourished, and then they'll have these pockets or these areas where there's a kind of abnormal accumulation of fat. And again, that's going to be a side effect of the antiviral meds that they're taking. Okay? So there are a lot of barriers. It makes it a difficult thing. And I can say that if I have a respiratory infection and the doctor places me on an antibiotic, am I always 90% compliant? Not always, but can you imagine these people are taking these meds for the rest of their lives? Okay, so that's a whole different kind of thing to think about. What else did I want to tell you? Oh, opportunistic infections, right? So remember we said that HIV is asymptomatic. It's not until you progress to actually having AIDS that patients begin to develop symptoms. And it's not the AIDS that could unfortunately kill a patient, it's the opportunistic infections that occur as a result of it. So as that immune system becomes more compromised, they're open up to developing different types of opportunistic infections, whether it's GI illnesses or whether it's pneumonia. This patient came in with pneumonia. That's often a significant complication of having HIV and AIDS. Okay? Couple of stages, two last things I want to go over with you. Okay, two last things I want to go over with you. Okay, so there are two ways that we can classify illness. And this is really looking at how we diagnose someone as having AIDS or if they actually have HIV. This is the let me back up. This right here, this process has 3 stages, and the stage that's listed on the board is the 3rd stage. This stage here, these guidelines are indicative of someone actually having AIDS, okay? And you'll see that the guidelines say if their CD4 count is less than 200 cells per microliter, which indicates that their CD cell count is dropping, right? That would be indicative of AIDS. If the CD4 count compromises less than 15% of the total lymphocytes, that's indicative now that they have AIDS, and or an AIDS-defining illness. That's referring to your opportunistic infections. So if you're trying to decide, does my patient have HIV or do they have AIDS? If they meet these criteria, then we would say that person has AIDS. So be familiar with the specific criteria listed here. You don't have to know the first two stages. I just want you to know the third stage, which indicates AIDS. And the third stage is the one that's listed on your slide. These categories are set by the CDC, so the Center for Disease Control. In addition to the guidelines set by the CDC, there's also the World Health Organization, or the WHO, which set guidelines as well. And this one has 5 categories of progression from that primary infection, which is that initial infection that we talked about, all the way down to clinical stage 4. There is a table that's listed in Blackboard with conditions related to each stage. I want you to be familiar with that. And let me just clarify, I don't want you to memorize all the conditions under each stage. Just know 1 or 2 of the conditions that are common in each of those stages. Again, this is another way to identify where in that progression from AIDS to HIV they fall. Typically, once they get to about clinical stage 3, that's indicative of having AIDS. This is just one of the opportunistic infections. It's actually an opportunistic cancer. It's called Kaposi sarcoma, and this is typically an opportunistic infection that you may see when someone develops AIDS. One of the other things you'll see is called lymphadenopathy. And if you break this down, this just indicates like disease or condition of the lymph nodes. And we find that the lymph nodes are kind of swollen over the entire body. We primarily see this during that primary infection. Why do you think those lymph nodes would be swollen? The body's trying to, remember that's that point where the immune system's overwhelmed, we're trying to develop antibodies. So the lymph nodes is where all of that comes from, right? So the lymph nodes are kind of swollen and tender because they're trying to develop antibodies to fight off the HIV. Okay, so we typically see this lymphadenopathy in that first stage, that primary infection. Yep, right? Sorry for the pictures. Oral hairy leukoplakia is a fungal infection that you may often see as well in these patients. Okay, I think the patient in your case study actually had thrush, which is another sort of oral irritation. So these are some things that can impact their ability to consume adequate nutrition. Often what they do if they have thrush or oral hairy leukoplakia, they're on medications to treat it. They'll also give them things that they can kind of use to deaden the mouth. But that probably doesn't do much for oral intake, but it kind of deadens some of the pain. This part is designed just to let you know that whenever someone has HIV or AIDS, it affects different portions of the body, okay? All portions are affected. One of the things I just want to point out, a lot of the medications that are used to treat HIV cause renal failure, so that's why patients have that. The GI disorders, that makes sense because of the macrophages. Chronic inflammation. Once seroconversion has occurred, patients enter a chronic state of inflammation, okay? Cardiac problems can result from the medications. And that other one, the altered nutrient metabolism, we touched on this a little bit before, and we'll definitely touch on it again. But whenever there's stress, remember how in cancer we said whenever there's stress, your body acts abnormally. doesn't metabolize nutrients the same. We see the same thing happening in patients that have AIDS and HIV. This is your goal for therapy. You want to lower the viral load. We lower the viral load by being compliant with medication. If we lower the viral load, we prevent the progression to AIDS. We want the viral load to achieve and maintain undetectable levels on a test. So when we test and follow up, we want that viral load to begin to decrease. Several combination of drugs are needed to do this, and we've talked about that. Overall goal, early treatment and prevention to help prevent nutritional decline and disease progression. Very straightforward, sounds very easy. I think the biggest take-home message here is prevention. Okay? We want to treat it before they become malnourished. This goes along with that. Prevent slowing and immune compromise, changes in body composition. We talked about the lipodystrophy. They look kind of like someone who is undergoing starvation, okay, because of their weight loss and fat loss is a combination of increased needs, decreased intake, and malabsorption. So we have all of these things working against us, okay? This is kind of what we talked about with cancer. If we get to a certain point where the patient is malnourished, it doesn't matter how much calories and protein we give them, it's difficult to bring them back from that. So this is why preventing it is such a big influence. Positive and negative acute phase proteins are continually produced because they're in a chronic state of inflammation. Not going to go over that right now. This just basically talks about what the needs are. We've kind of already gone over that. We know that needs are going to be increased. Okay, there are no specific guidelines to remember. Needs are going to be increased. We base it on the patient's stressors. Okay. Did you find the case study helpful? Okay, I wanted you guys to get practice going through that whole process, estimating needs when you didn't have the guidelines for you to use. Any questions about AIDS or HIV? So on the test, if I had a case study where someone had AIDS and I was asking you to calculate out needs, you're going to do exactly what you did in class today. Okay? All right, no specific guidelines. All right, so just a reminder, we have a case study due next week, right? It's due in Blackboard by 10. I don't think the case study, the copy that I gave you, has height and weight on it, so I sent out an announcement yesterday that has height and weight, so use that for your calculations. Key for the case study we went over in class will be posted over the weekend. The test, I do apologize, had a loss of a family member over the past week, so it's been a little crazy. I don't usually take that long to get the test back, but I will have them posted over the weekend, okay? So if things are not where you want them to be, that's the time to